you're a patient. So again, who are we doing this for? This is for no company. This is for no one but the patient. And so if what are some of the questions maybe I have forgotten to ask or have overlooked that you might have had other patients in here or dealing with other patients that would be a topic on the teeth and the final teeth and that type of situation? Is there anything I'm forgetting or I overlooked?
So I don't necessarily think so. I think you made a very good point about patients coming in with an idea. That's the most important thing, because some patients, either they just don't care and they're here for function, and then there's some people that just want function and then they want it to look the same, or they want function and they want to change it up a little bit, right? But I think that's a very good point, to make sure that people come in with that idea. But as far as like questions, there's nothing clinically I can think of. At the end of the day, the questions you're going to ask when you're visiting a certain clinic is, what are they doing? Are they doing it analog style? Are they taking impressions? I mean, it can all be done the same way. It's just the digital is the way it's going now, and it's less alginate in the mouth, less time, in my opinion, in certain work areas, right?
Is it less margin of error? Because you go analog versus this. Is there a greater margin of error? That's one of the things I was trying to figure out.
So it's kind of, there's error on both sides, right? So, I mean, if for some reason, and this is anywhere, right? I've talked to a few clinics before and they were looking at getting into digital and they're like, okay, so it's easy, right? And it's like, there's a learning curve, right?
Sure.
Are you good with computers first off? And they're like, yes or no. And I'm like, okay. If they say no, it's like, okay, reevaluate, right? If they say yes, that's okay. Well, then have you done any type of intraoral scanning in the mouth before, right?
Okay.
And they say yes or no. And it's okay, well, you said no, maybe start with just doing crowns first, like single crowns, getting an understanding of the scan pathing, and understanding when you have a bad scan. I've seen scans before where if they would have sent it to me, we would have caught it obviously, but it would have been a waste of chair time for the doctor, right? It would have been a waste of our processing time to look at it and go, hey, or if someone would have missed it, we would have designed through, and then guess what? It doesn't fit in the mouth. But that's why our lab here has certain like protocols where it gets caught before it even gets to the end, right? So, like I said, if you take a bad impression, you're going to have a bad fit. If you take a bad scan, you're going to have a bad fit, right? So at the end of the day, it's just someone like Dr. Ratana, who's very comfortable with doing the intraoral scanning and understanding the photogrammetry, and him being a CDT, understanding the design software and how we correlate all this data. That's the biggest part, is knowing how to correlate it. It took us a few weeks up to a month to figure out, even with the iCam, how to correlate that data to get it correct. Because it's cool if you can just get the scan. Yeah, you can take the scan in 30 seconds after you calibrate it, but the long part is making sure that everything is correct. So once we got all that going, now it's night and day. Like, some places they want 100% digital. In my opinion, there's some things that should stay a little analog. I think that it doesn't make sense to make it fully digital, just for the time's sake.
Give me an example, Zach.
Like, for example, so this is an example where digital is really good, right? So let's say you came in, and I think this is what we did on your last appointment. We scanned physically, right? We scanned in your mouth, right? But then the time before that, we actually took the appliance out and we mounted it. That appointment was much longer, right? Now, the reason we had to do that is because we had a bite issue, right? And we wanted to make sure it was right for the next delivery. That's an instance where it makes more sense to go fully digital, right? Because you can scan everything. And we did the scan in 30 minutes and you're out and you're on your way. But when we have to do an analog, we have to physically take it out. We have to take the blue bite, we have to mount it, we have to pour the model, we have to do all that kind of stuff, and that all adds time. But as far as like, so an example where it may make the same amount of time is night guard. There's a plus to having a digital scan and making a physical night guard digital and having the file forever, because you can just reprint it whenever it comes up. That's where on that side the digital makes sense. But let's say you come in and you're not a heavy grinder, right? We just take an impression, someone pours the model and they make the night guard and they deliver it. In a sense, it doesn't take as long to design the night guard digitally and then printing it. So it's not, when you're printing the night guard, you're not sitting there for the whole hour watching it. But it's time something else could be printing too. So if you print the night guard, the only time associated with printing the night guard physically that's like you doing it is nesting it, designing, nesting it, and then the finishing after, which the finishing, depending on how you do your supports and how you angle it, could take long too.
For a night guard?
For a night guard, yeah.
Really?
So, because when you're printing it, that's a whole different story now. That's a whole other ballgame when you're printing. it's additive, right? It's not reduction like these mills. But when you're doing additive, you have to have the correct supports to support the structure, or it won't print correctly. And that's, I see a lot of that in the Facebook forums on, hey, why isn't this printing? And it's simple as how they angled it or where they put their supports, right? But so if you look at it as doing like just an analog night guard, like it could be done. Yeah, you had to take time to pour it and then do your mounting and then do your suck down and then cut it and finish it. In my opinion, sometimes that could be faster with the right technician that's skilled to do a night guard the analog style. But if you have someone who can design it quickly and then nest it quickly and then print it, it's about the same time.
Okay.
But the benefit of having the digital is you always have that 3D design. Now, let's say you come back and you make an adjustment or you lose a tooth or something. Now we have to kind of redesign that. So if everything stays the same forever, yeah, we can just reprint that same night guard, reproduce it, mail it wherever you are in the world, or have you come in and deliver it. But if something changes at that point, you almost have to take a new scan. But that's just how it is.
What about the lower? So my example, upper's done. That's what we're looking at clearly. If I had something change on the lower, would I need to adjust my night guard?
So everything that we're going to do, like this upper, right, was designed to your natural lower. So if something, let's say like we're talking about with that crown, not necessarily. They may have to adjust a few points on the night guard. But when they're designing that night guard, they should keep in mind that there's probably going to be a crown there eventually because there's an implant there. We can see it in the scan. So we have to have a minimum thickness for the night guard for it to be useful so it doesn't break long term. If we make it too thin, it doesn't really last too long, and then we're probably going to be remaking it a lot. So in a situation where you're coming in and they should design it, for example, we know you don't have anything here, right? We talked about finishing this upper and then doing your lower. The lower shouldn't go anything crazy. Like it should almost match what's around. A little more anatomy, but it shouldn't affect anything super drastic. So an example where we would want to remake your night guard though is let's say something happens and it chips. Let's say something chips here or on a incisal edge and we have to remake it. Obviously, we're going to try to make it match as much as possible, but if let's say you go to put your night guard in and it doesn't fit, or let's say you make something, a drastic change, you want something slightly changed, then we would have to rescan and remake that night guard.
Okay.
So it's all situational, I think. Like sometimes it's just, hey, we made this change, let's just do it on a model, pour the model, do the night guard suck down, cut it, and then send it out and be done. Or if nothing's changed and everything's perfect, then just reprint it and then deliver it. And we've had both situations, but it is truly situational, I think, in that in that circumstance of is it better digital or analog.